Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit OIEBroadcasting.com and sign up today.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Subthreshold MicroPulse Laser Treatment, SMPLT, is emerging as a new non-invasive and effective treatment in selected cases of retinal disease. Currently, MicroPulse retinal laser treatment has been underutilized by retinal surgeons. MicroPulse lasers are considered safe, cheap, and when compared to classic laser photocoagulation, it leaves the retinal cells intact with no detectable damage to the RPE or photoreceptors. Today's guest, South Florida Vitreo-Retinal surgeon, Dr. Walid Mangal, lectures and teaches MicroPulse laser and has used it successfully to help thousands of his patients. Dr. Mangal, thank you for joining me today.
Dr. Gelb, I appreciate you having me on. It's a really great honor to be here.
I'm so excited to talk to you because you're doing something that a lot of the doctors aren't doing and that could help a lot of people. Tell us how you got interested in MicroPulse laser treatment.
So, the first time I used MicroPulse laser treatment, I was in my retinal fellowship in 2012. I had done probably hundreds of lasers throughout my ophthalmology residency in Philadelphia, but I didn't have access to MicroPulse laser. And at the time, it was kind of an emerging technology. And when I started my fellowship in Baltimore was the first time that I used it, and I understood how it worked. And my mentor, who is a world-renowned retinal specialist, was really kind of a very cutting-edge retinal surgeon. And he was always on the forefront of new technologies. We had access to multiple different types of modalities in our fellowship program, and so we had yellow lasers, green lasers, red lasers, MicroPulse lasers, regular argon lasers. And so, we really had a full armamentarium of lasers to treat different kinds of retinal disorders. And so that's when the first time it was that I used MicroPulse laser.
Why do you think that more retina specialists aren't using it?
Part of it has to do with the fact that a lot of retinal surgeons, especially in the last decade, have kind of moved away from laser treatment. The injections have taken center stage. And of course, anti-VEGF injections are revolutionary. I mean, before the injections, treatments were really substandard. And a lot of times they would, laser a CNV lesion in the eye, a bleeding in the eye, and they would stop the bleeding, but they would leave a massive scar. So when the injections came, the pendulum swung completely to the other direction. And when that happens, from what I've noticed and from what my mentor had trained me in fellowship, he said, you'll see this in your career. When something new comes, everyone rushes the other way. And the things that have been working, they almost sometimes neglect. And so if you really want to be a good doctor and a good retinal specialist, you really want to keep, all options open. You want to keep all options on the table. You want to tailor it to the patient. And so when these injections came, people kind of forgot about lasers, but lasers still work. I mean, not everybody needs an injection. I mean, I do injections as far as the eye can see on a daily basis, but I also use laser in my clinic. And there are patients who are perfect candidates for laser, who you don't have to put a needle in the eye to. You don't have to commit them to monthly injections, especially in diabetic patients. Who gets diabetes? Younger patients, 20s, 30s, 40s, 50s. These are patients who are working. They have things to do. They have families, they have children, they have jobs. And really, to commit every single one of these patients to an injection on a monthly basis is really asking for a lot. And you wonder why some of these patients don't show up to their appointments. They'll get 1 or 2 injections and then they say, you know what, I'm just too busy. I can't keep coming to these monthly appointments. That's a perfect situation where a patient can benefit from a laser treatment. You can see them back 3 months, 4 months, 6 months later, reassess and reapply if needed. So it works for the patient, it works for your clinic, and it probably saves the healthcare system money because you're not doing $2,000, injections every month on a patient. So, I like to incorporate it in my clinic, but I understand why so many doctors have kind of moved away, because they've all ran towards the injection treatment, and they've kind of neglected this tool.
I mean, that's a great point. I mean, asking a patient to come back every month or every 6 weeks or even every 2 months for an injection is really asking a lot of a patient, and it's understandable why people may drop out. So let's go through the different lasers. I think many people are confused about the different lasers, from the red laser, the 695 to xenon to argon to MicroPulse, even YAG. Tell us about the different lasers and how they're different and what they're used for in a different way.
Right. So the 2 common lasers that we use in present day are really red lasers and green lasers and yellow lasers. And these are the most common ones that are used today. And you can use both of them to treat different kinds of retinal disorders, such as diabetic macular edema, tears in the retina, and so on and so forth. Those are the 2 conventional ones. And then you have this category of MicroPulse laser. Now, certain companies make laser units where you can do it in a continuous way, or the standard way of doing the laser, or you can switch the button and switch the laser into a MicroPulse laser. And there's really a key difference between the conventional laser and the MicroPulse laser. When you're using a continuous laser or the standard laser, all the same name, when you fire the shot, the laser delivers that power continuously during that time period. And what that does is it leaves a little scar on the back of the eye. And sometimes you want that scar in the back of the eye, especially if it's in the periphery of the retina. For example, when you're treating a retinal tear, you want the area around the tear or around the hole to form a scar to kind of cement the retina in place to prevent a retinal detachment. But when you're treating problems in the macula, you don't necessarily want a scar. So this is where MicroPulse really fits in. The way the MicroPulse laser works is it chops up the laser. So instead of that same power being delivered the entire time, it chops up the laser into tiny little bits. So it never heats up the retina, and therefore it never leaves a scar in the back of the eye. And that's the beauty of the MicroPulse. It does not leave a scar, not to mention you don't feel it. So, using conventional lasers, sometimes when you're treating the patient, they really feel that. I mean, it can be really painful for them. But the MicroPulse laser, you don't feel a thing. It kind of, if you really put it in layman's terms, it tickles the retina enough to activate the cells in the retina, in the bottom layer of this retina, to kind of suck out the fluid, and which reduces then the swelling in the back of the eye. So that's the difference between the 2 types of lasers.
Now, the multi-laser platforms that Lumina, Zeiss, Nidec make, they'll make it with many different, they'll have green and yellow, and you'll be able to switch back and forth. Do they also have a multi-pulse on that? Can you use multi-pulse with those multi-laser platforms?
You can. There's multiple different companies that offer that technology. Now, the word MicroPulse really, Iridex was the first one that really came up with it. So they've trademarked it. So the other companies, they use a variation of the word MicroPulse. Some of them will call nanopulse or so on and so forth. But it's really the same technology. It's taking a laser that's continuous wave and chopping it up into small little bits and then delivering that to the back of the eye. And the efficacy between whether you're using a green laser or a yellow laser, it's not really a big difference. We've tried both of them. I've used both of them in my fellowship program. There's really no efficacy difference between one or the other. Either one works. Whichever one that you have access to, I think is a great thing to have in the clinic.
So a retinal surgeon that is using these multi-platform lasers, whether it's from Zeiss, Iridex, Nidec, it'll have MicroPulse on it. They'll be able to do MicroPulse.
Yes, some of those units are multimodal, in which case you can switch between continuous wave, also known as standard laser, or you can switch it to the MicroPulse mode.
So explain how lasers work in the retina and how you're using a laser. Whether you need that scar, is it important? If you're using a regular laser photocoagulation, do you need the scar for it to work? Is something being released to prevent neovascularization?
Wonderful question. $1 million question, really, if you think about it. I want to start the answer with a quick story. So 2012, I had just started my retinal fellowship. And 4 years before that, I had done a very busy, intensive ophthalmology residency program in Philadelphia. And so I had hundreds of lasers under my belt coming out of residency. And in my residency, I knew I wanted to be a retinal specialist. I spent a lot of time with the retinal surgeon on the retina service. Even when I was doing a glaucoma rotation, I would finish clinic by 4:30. And I would, instead of going home, I would go over to the retina side and stay there till 6, 7, 8, 9 p.m. and then go to the OR, sometimes stay there till midnight, just because I knew this is what I wanted to do for the rest of my life. So I had a lot of experience in retina, or so I thought. And so in 2012, when I started my fellowship program in Baltimore, my first week of retina fellowship, we had a diabetic patient who needed laser to the back of the eye. I did the laser, and at the end of the day, we would go through the different charts and kind of talk about them as a group. We'd set my mentor and all the fellows, and we would go one by one, and he would ask us questions. And so, I did a standard laser, pan-retinal PRP laser to the retina for a diabetic, nothing fancy. I had done it hundreds of times. And he said, Walid, tell me what you did. I said, well, the patient had proliferative diabetic retinopathy, bleeding in the eyes, leakage vessels. I did pan-retinal laser to the back of the eye. He said, okay, good. Can you tell me how laser works? And, I hit a blank. I spent 4 years in my residency seeing probably a few thousand patients, doing hundreds of lasers, and I didn't quite understand how that laser worked. No one ever told me, and I couldn't figure out why I didn't learn it in residency. The answer is because no one really knew exactly how laser works, and this has been a kind of a topic of great discussion in the retina field. And it's one in which there's been a kind of a paradigm shift over the last few years. In the early days, in the 1940s and 1950s, there was some hypotheses floating around. They thought that, delivering laser to the back of the eye increased oxygenation to the retina. Then there was another theory, maybe delivering laser to the back of the eye, destroyed these, what they used to call in the 50s, factor X producing cells. Now we know those as VEGF producing cells. So there was this hypothesis floating around. And then a few decades went by. There was work done at Harvard by two really well-known retinal specialists, and they found that the eyes that had scars in the back of the eye, due to whatever reason, they tended not to get as bad diabetes in that eye versus the other eye that did not have scars. And so they thought of an experiment. Why don't we do laser to the back of the eye and cause scars and see if that reduces the chance of diabetic retinopathy? Sure enough, it did. Then they used a different laser that left minimal scars. Same outcome. Minimal scars, diabetic retinopathy went away. And then massive scars, same thing. Moderate scars, same thing. And so the question became, do you really need a scar in the back of the eye to cause regression of diabetic retinopathy, reduction in swelling, et cetera? And the answer is probably not. And we've really come to understand that really in the last few years, maybe in the last 5 to 10 years. And this has been something that, we've been trying to understand for decades. So this is where the MicroPulse laser really fits in. So now we know you don't really need to form a scar on the back of the eye. And most likely what's happening, and this is new information, is that lasers, it's not the scar that's causing the regression. It's really the act of delivering laser to the back of the eye causes release of inhibitory cytokines, basically chemicals that are suppressing the progression of diabetes in the back of the eye. And so it's the release of those chemicals. It's a biochemical process and not really one where you're just torching the back of the eye with a laser. It's really a biochemical process that's causing regression of diabetes and control of diabetes in the back of the eyes.
I think one of the most amazing things about MicroPulse is it increases heat shock proteins. And heat shock proteins is used as a protective mechanism because it protects the cells. It increases new proteins. It increases nitric oxide. It limits apoptosis. And it decreases toxins. So if you could talk about how heat shock proteins are used in the retina and being released from the MicroPulse laser.
Yeah. So what happens is, again, this is all, when I say new, I mean in the last few years. So they've discovered, because the question became, well, if MicroPulse works through release of inhibitory cytokines, what if we take cross sections of an eye, of an animal eye that's been treated with MicroPulse laser, and let's see the histologic changes that are happening in the eye, and also let's check to see what other chemicals are being released. And this is when they discovered the upregulation of the heat shock protein. When they started to look at histological, so although at the naked eye, in the clinic, when I'm doing MicroPulse laser, I'm not seeing any blanching of the retina. I'm not seeing any scar formation. If I do that laser and you go look at that eye a day later, a week later, you would never know that I had done any kind of laser to that eye. So it leaves no marks. So then you're wondering, well, maybe the changes are microscopic. And now they're discovered that yes, MicroPulse does cause microscopic histological changes and also a biochemical reaction that's releasing heat shock protein, which does all the things that you mentioned in the back of the eye.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
I know from heat shock proteins because I have an infrared sauna, and I use my infrared sauna as protection to release heat shock proteins throughout my body as kind of a anti-aging type of situation.
Outstanding.
So I've been doing that for quite a while. So, but when you mention the MicroPulse laser, if you look at it with fundus autofluorescence or OCT or regular imaging, we don't see any marks at all. Is that correct?
That's correct. Yeah, it leaves no marks at all. And if, like I said, if I did the laser and you saw the patient a week later, you wouldn't know that I had done MicroPulse laser to the back of the eye.
This is amazing. This is amazing technology that we could be using on our patients on a regular basis. So explain the technique. Is there any separation between the laser marks, or is it pretty much like zero separation? And how much energy is being used?
So, with conventional, I'll just compare it to your standard conventional focal. So when we're doing conventional focal, you get a fluorescein angiogram, you see the areas where the little microaneurysms are, you see which ones are leaking and causing the edema, and then you just treat those specific microaneurysms, staying away from the fovea. I mean, it was drilled into our heads as residents. When you're doing this laser, avoid the fovea, stay away from it. You don't want to leave any scotomas. You can't reverse it. It will be a disaster if you fire a continuous wave laser right into the fovea. On the other side, with MicroPulse, it's the exact opposite. Not only do you just do a few spots, you carpet bomb the entire fovea and all the entire macula. So you literally laser right on top of the fovea. You go start from the top and just go round and round and back all the way up, and then go back around. And the power that we use for conventional focal, 80 milliwatts, 60, 100 milliwatts of power. On the MicroPulse, I'm using 400 milliwatts of power. However, it's on a MicroPulse mode on a 5% duty cycle. That means that laser is only firing 5% of the time of a continuous wave laser. And if you do the math, that power is significantly less than 80 milliwatts or 100 milliwatts that you would use in a conventional laser, which explains why it doesn't leave any scars. But MicroPulse laser will not work if you just do a few spots. We know now that you need at least 400 total spots of MicroPulse laser in order to start to see efficacy. And so in the early days of MicroPulse, some doctors tried it. They fired 50 shots, 100, what they thought was a lot. Wow, 100 shots of focal. I've never done that before. They would shoot 100, 150. They said, this thing didn't work. And the reason it doesn't work is we need adequate enough laser. It was inadequate treatment. And so if you fire at least 400 shots, carpet bombing the entire macula, going all the way through the fovea, that's when you start to see response.
And how long does it take to fire 400 shots?
A minute and a half to 2 minutes. You know,
So
depends on the interval of the shots. I tend to shorten the interval so that it's a rapid fire kind of a situation with the laser when I'm doing MicroPulse.
And does the patient feel anything at all?
Zero pain. And in fact, that's what I tell the patient. I'm going to do a laser for the back of the eye. This is a very gentle laser and that there's zero pain at all.
And is it ever used in combination with anti-VEGF treatment, or is it typically standalone?
Most of the time you use it as standalone, but there is some data that, you know, when you're treating patients with anti-VEGF, either in a diabetic patient or maybe in a patient with wet macular degeneration, where the anti-VEGF is not enough, you're treating the patient every 4 weeks and they have kind of persistent subretinal fluid, persistent edema, then what do you do? And in those cases, they've incorporated a MicroPulse laser and they see that there is an improvement in efficacy of the anti-VEGF agent. And the hypothesis is that the MicroPulse causes kind of a reactivation of the receptors within the retina, which then makes the injections work better.
Let's turn our attention to something that is very effective with MicroPulse laser. It's central serous retinopathy. Can you explain central serous? And then after you explain the disease, then let's go into how MicroPulse could be used for it.
Sure. So central serous retinopathy, it's really a disorder of the retina that affects younger patients. So patients between 30 and maybe 55 years old. And what happens is some patients, where they're exposed to steroids, whether they're taking the steroids by mouth, inhalational, topical steroids, you know, creams for itching, itchy skin, cortisone injection into joints. This is a big one. A lot of patients, you know, get injections into joints of cortisone, which is a steroid. Or if they're under stress and their body is releasing a lot of cortisol, which chemically is very similar to a steroid, some of those patients can then develop fluid under the retina. And when you get fluid, the vision becomes blurry in that eye. You know, the image looks smaller, color perception can be off, the vision is blurry. And the good news is what, you know, more than half the cases of central serous retinopathy does not require any treatment. You know, if I see a patient, refer to me for possible CSR, the first thing I do is just kind of leave it alone. I'll give it another month and a half. And a lot of times the fluid will start to come down on its own. But there's some exceptions. What happens if the fluid is not going away? What happens if the fluid is taking a long time to resolve? What happens if the patient is a very high functioning person and they really need pristine vision to do what they need to do? For example, you know, accountants, other surgeons, you know, pilots, many other industries where the patient needs really good binocular vision. And in those cases, you really can't let them suffer for another month and a half and 2 months. And in those cases, MicroPulse laser is the perfect option to use.
Now, do you feel that central serous is really a pathology of the choroid?
You know, I think so. There is some data that, you know, and it's still not 100% understood, but they really think that in some of these patients, they used to think it was a retinal issue, but now they're realizing it's an RPE and choroid issues. And now they're able to get imaging underneath the retina, go deeper into the choroid. They're realizing the choroidal vessels are actually dilated in patients with central serous retinopathy. So there's something going on there that causes the RPE layer of the retina, which is, I think of it as like the sump pump of the retina, to malfunction. and it's not able to pump fluid out, and the retina starts to accumulate fluid underneath. But it's probably a choroidal issue that's causing the problem.
Typically, it's that the retina specialists wait 3 to 4 months before they would treat it with standard laser photocoagulation using, first they would use fluorescein angiography to see where the leakage is of its 300 to 400 microns away from the macular. They would use standard laser photocoagulation. But if it's in the center of the retina, that's when the problems exist. But I want to mention to you that I personally feel that people with central serous should be treated really immediately. And I'm going to tell you why they should be treated, or within 6 weeks, is because I've had 3 patients in my career who've had central serous, who it became long-standing, and then the pill line, the photoreceptor integrity line, or the cones were damaged, and then the patient lost best vision. The patient waited, myself together with the retina specialist was decided to let the patient wait. Damage was done, and there was nothing that could be done for those 3 people that I've seen over my career. And then when I heard you speak on MicroPulse laser, I said, something, because, we're getting close to 60 to 80% of the people that get MicroPulse get resolution of the edema from MicroPulse laser, that why, and because it doesn't cause any damage, why can't it be started earlier? Because if somebody is unlucky enough to be one of those people where they get damage to the photoreceptor integrity line or damage to the cones, they don't get their vision back. And I've seen it happen 3 times already. And I would like for you to comment on that.
Yeah, I think that's an excellent point. It's one of those things where, you kind of think of it as, well, this is something that resolve on its own. But at the same time, I would not recommend waiting 3 or 4 months. I certainly don't. I mean, I see them back 4 weeks, 5 weeks, 6 weeks. And if I see fluid still there, I treat on that visit, on that second visit. That's kind of my go-to. I don't like to wait long. And it's for the exact reasons that you mentioned. The longer you let that fluid linger, whether it's central serous, whether it's diabetes, whether it's macular degeneration, those photoreceptors get really beat up. And if you somehow later on get resolution of that fluid, that vision's never the same. And, a lot of times the doctor will say, oh, you look great. And the patient's like, well, how come I don't see great? The OCT will look great, but, we're not treating the picture, we're treating the patient. So I agree with you that it's better to be, especially if you have a treatment option that has minimal really to no side effects, why not treat early? Why wait and let things get worse? And then you're kind of behind the ball. And then if you really get the fluid down, at that point, the vision is never going to be the same.
How often do you see central serous in both eyes? I know it's reported. I personally have never seen it in both eyes.
Yeah, I have a few patients, probably 95% of patients are unilateral. 5% or less, I have a few that are bilateral, and the bilateral ones are the chronic patients. They've had chronic CSR, seen multiple retinal specialists. I've had multiple different kinds of treatments, everything from, continuous wave laser to PDT to even pills. I mean, there's a class of hypertensive drugs, spironolactone, or a bunch of other ones in that category that has been shown some response to in CSR patients. And when nothing works, then what do you do? So those are the patients that I see, and then I offer the MicroPulse laser treatment for them.
You mentioned photodynamic therapy, and that is used sometimes for central serous. Can you explain what that is and why MicroPulse would be better than that at this point?
Yeah, PDT has really kind of fallen by the wayside. There's very, very few retinal surgeons that use it. I don't use it in my clinic. My kind of algorithm for treating CSR is, wait a month or 6 weeks, if not better, treat with MicroPulse. And if it's improving but not gone, just retreat over time until that fluid is completely gone. Now, there are some cases of CSR where you get not just the subretinal fluid, but you actually get a CNV, a choroidal neovascular membrane component to it. you cannot get rid of that membrane with just laser or micropulse laser. That's a situation where you may need to do combination treatment, an anti-VEGF injection and micropulse together in different time points, but kind of combination treatment in that way. And PDT basically, involves, they kind of sometimes call it a cold laser. It works in some cases, but then it doesn't work in other cases. And there's restrictions on the patient on how often they can be in sunlight. And again, most people don't even have the equipment for PDT because it's really kind of fallen by the wayside. I certainly don't prefer it. It's not my go-to treatment of choice. I never use it.
Talk about fluorescein angiography. How can fluorescein angiography help with central serous?
Yeah, excellent question. I want to kind of talk about fluorescein angiography a little bit. So just like the injections came out and, everybody kind of rushed to the anti-VEGF camp and almost neglected all the other treatments that are available for retinal specialists, the same thing has happened with fluorescein. Fluorescein was the imaging modality for decades. And then OCTs came about. And so now that OCTs came about, OCT is the standard of care. It's the minimum imaging modality that you need in a retinal clinic. But OCT, again, has almost become the only imaging modality for some retinal specialists. And as good as an OCT is in finding different intricacies of retinal disorder, you can't catch everything on an OCT. You really need a fluorescein angiography in many, many different retinal conditions. And I've seen diagnoses go completely missed because no one ever got a fluorescein angiogram on the patient, or a diabetic exam that looked kind of benign. Okay, maybe a little bit of microaneurysms here, a few dots here, doesn't look that bad. I guess it's fine. And maybe it's mild, non-proliferative diabetic retinopathy. And you get a fluorescein angiography and you see widespread ischemia in the retina. Patient is a type 1 diabetic of 30 plus years, and there's ischemia everywhere, and there's neovascularization in the periphery that was totally undiagnosed. So fluorescein angiography is a fantastic tool in a retinal clinic, and I really wish more retinal specialists did more fluorescein angiography. I understand it causes inefficiencies in the clinic and slows things down a little bit, and you have to inject something, it's invasive, but I really wish they perform more of it. I feel like a lot of retinal specialists have kind of moved away from it, almost to a fault in some cases. So an FA, as it relates to CSR, in CSR, you have a leaky spot, at least one or maybe more than one, underneath the retina. You really cannot see that leaky spot, or what we call a hot spot, unless you do a fluorescein angiogram. And when you do, you'll see a nice little spot on the FA, exactly where that leaky spot is in the retina that's causing the problem. And that's important because if you decide to treat, let's just say you don't have micropulse modality available. At that point, you can use a continuous wave laser to treat that hotspot to make the fluid go down. And if you have micropulse, you don't even have to worry about the continuous wave. You can just use micropulse to treat the area where the leakage is.
Now, continuous wave, is that going to cause scars?
It does in most cases. You really want to minimize it by using a very low power, and preferably it's hopefully not anywhere near the fovea, but it does, yes.
So you have to be 300 to 400 microns away when you're going to use that type of technology.
Preferably, yes.
So how do we avoid where we get improvement in losing the edema from MicroPulse laser, but we also want to have improved vision as well, not just improved fluid being left, but also improved vision?
You mean, how do you accomplish both?
Yes, to improve vision, best visual acuity,
Right.
and after treatment, as well as losing the edema.
Yeah. So a couple of things. Point number one is, and I've learned this in my fellowship program really heavily, is that the OCT doesn't always correlate with vision. You may get a patient where the OCT looks incredible. The fluid is gone, patient's unhappy. The vision is not ideal. They're not happy at all. And you're kind of confused about, well, the OCT looks good, why are you not happy? And vice versa. You'll have cases where the OCT looks horrible. And you look at the vision and it's 20/30 or 20/25. And you ask the patient, how's the vision? They say, I'm fine. So it doesn't always correlate. Now, the nuance of that is intraretinal edema or swelling tends to correlate with worse vision. Subretinal fluid tends to correlate with not as bad vision. So the goal is really to accomplish both. And part of that is what you mentioned earlier. Start the treatments early. Don't wait until that photoreceptor layer is all beat up. And then at some point you're like, oh man, I think I'm going to treat this. I think I'm going to do something about it. You want to have the right level of aggressiveness, not too aggressive, but also not too complacent as a retinal specialist. So treat early, especially if you have a modality like MicroPulse with minimal to no side effects. And second part of it is, assess the patient. Sometimes not everything needs treatment. You'll see a little bit of a cystic swelling on the macula, on the OCT, and you ask the patient, how are you doing? They say, I'm fine. So is it really worth putting a needle in that patient's eye, putting a chemical in their eye, risking getting endophthalmitis, committing them to monthly injections if the patient feels that they're fine? Probably not. Now, of course, there are cases where, you can have, for example, I'm using an extreme example. You have a patient with a retinal detachment. They haven't noticed symptoms yet, but it's an acute retinal detachment. It's superior. It's only a matter of time until that patient starts to lose vision. In that case, in those rare cases where the patient doesn't realize it, but they have a retinal detachment that's advancing, you need to talk to them and say, listen, you need surgery. I know you feel like you're fine, but if you wait any longer, you're going to lose your vision. So those are extreme kind of examples where the patient feels like they're fine, but yet you still need to intervene. But by and large, with the exception of those extreme examples, the goal is treat early, have a good conversation with the patient, understand where they are. And if they're symptomatic and you see the problem on the imaging, that's when you want to treat early.
Yeah, I think that's a great point. You got to treat early because you don't want those patients to wind up with poor vision, and you're releasing those great heat shock proteins that are so beneficial to the retina.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.